Welcome back to About Health. I'm your host, Dr. Mike Lenoir. You know, the Affordable Care Act is now law of the land. We've had a one-year experience with the Act, and we're about to go into a new enrollment period. So I thought it'd be a good time to discuss the Act, what's happened, what the future looks like, and we're lucky to have as our special guest, Mr. Gregory Kats. He's the Affordable Care Liaison for San Francisco County, City and County. Mr. Kats, thank you for joining us.
Thank you for having me, sir.
One-year experience, how well have we done in the Bay Area?
Well, sir, I'd say we've done phenomenally well. When this legislation, the Affordable Care Act, was enacted back in March 23rd of 2010, the initial projection was that about 35 million Americans who didn't have access to affordable health care in the past would gain access as part of this legislation. Here in the Bay Area, we've really been spearheading that effort, and I think the numbers speak for themselves in terms of our success. We've had, as of August of 2014, about 67,000 new entrants into our Medi-Cal rolls, so that's 67,000 people who've gotten affordable health care through Medi-Cal, and about 40,000 people within our region have signed up for Covered California.
And when you talk about, San Francisco is kind of unique in the Bay Area because you already offered a kind of a free health care system for most residents of San Francisco. How does this act interface with that particular plan?
Well, so prior to the implementation of the Affordable Care Act, we actually had universal health care coverage through the San Francisco Health Plan, Health ESF. And at that time, that was really the only option that was given to people who could not afford healthcare through a lot of the regular forums. But now, now that the Affordable Care Act has been enacted, that program is really being used primarily for undocumented citizens of the city. And we've really created two main forums for people to access affordable healthcare in San Francisco. One thing we've done is we've expanded Medi-Cal coverage to include single adults. Prior to the implementation of the Affordable Care Act, Medi-Cal was mostly reserved for seniors and the disabled. But now that this program has been opened up to a wider audience, we've had single adults who are below 138% of the federal poverty line are now eligible to become covered under that program, and also children who are below 250% of the federal poverty line. To make that number a little bit more accessible for the folks watching, for a single adult, 138% of the federal poverty line is about a little over $16,000 a year, or for our family of two, we're talking about a little bit over $21,000 a year in income. So that's a underserved population in the past that we've been able to serve and to cover through the opening up of Medi-Cal as part of the Affordable Care Act. We've also been able to establish an online marketplace called Covered California, which is really for people who are between 138% of the federal poverty line, who don't really, they're not eligible for Medi-Cal, and people who are under 400% of the federal poverty line. And those individuals can shop online for affordable health care. They have options such as Kaiser, options such as Blue Cross available to them, and through Covered California they can gain access to coverage. And for some of them, ones that are below 400% of the federal poverty line, those people can actually get subsidies in the form of tax credits to help them finance their coverage.
So you had a year's worth of experience knowing the Bay Area. You probably done some assessment on satisfaction with the program, the expanded benefits for Medi-Cal. What's people's feeling about it?
Well, overwhelmingly, as far as the services go, as far as access to health care, as far as the quality of health care that people are getting, we've had a very positive reaction. I think a lot of people are very happy to have access to preventative medicine, which is something that they haven't had access to in the past. For a lot of our clients, especially our single adult Medi-Cal eligible clients, this is a population that really waited to be served until there was a medical emergency. And then they would go out and they would go to the emergency rooms and they would have their health care needs addressed in that way. So they were really waiting until a crisis point in order to get services. Now, with the implementation of the Affordable Care Act, one of the things that has really changed in the nation's healthcare structure is that people now have access to preventative medicine. Services like maternity care, prescription medicine, mental health and substance abuse services, really a wide array of services that people can access before they reach that crisis point so that they can keep themselves and their family healthy. The only challenge that we've had is really the success that we've enjoyed as part of this program. We've had a lot of applications coming in since this legislation was enacted and since we opened up the Medi-Cal program. So we've really been relying on our community partners to help us in terms of new applicants, to do outreach, to help them with enrollment, especially with open enrollment coming up in November 15th, 2014. And that open enrollment will last until February 15th, 2015. We really need all our partners out there in the community to help our clients enroll, to get the information out there about this service, and to make sure that people understand the paperwork and that they're accessing the various portals that you can use to sign up for ACA.
Now, you've been in health for a long time. You must be, you watched the whole system evolve. You've seen it come from a place where almost these people had no services to now there's, how are you feeling about that?
I mean, it's absolutely wonderful. You know, when I see underserved communities in San Francisco, the Excelsior, Bayview, Hunters Point, the Mission, areas that have traditionally not had the access to services that a lot of the more affluent areas in the city have had, to see those people gain access to one of the most fundamental rights, and that is access to affordable health care. I mean, it's very gratifying, and I think it's something that the community truly appreciates.
Well, Mr. Kats, we want to thank you for your involvement. I think it's investment of people like you that have made the implementation of the Affordable Care Act in the Bay Area such a success. Thank you for joining us.
Thank you for having me, sir.
We'll be right back after this break.
It is so easy to give back.
I don't have a lot of money to help people, but I do have something. I have time.
Get up and do something.
Just imagine how strong a society we could be.
Every one of us has a role to play in making our communities and our country stronger. Discover yours. Help us continue to make a difference in the life of our nation. Go to serve.gov and find the opportunity that works for you. And this message is brought to you by the Corporation for National and Community Service.
Our nation's future depends on what we do today to prepare our young people for productive and fulfilling lives. All of us need to get involved to help kids stay focused and stay in school. We must become a nation of graduates. One way for you to help is to volunteer as a mentor. Think of a mentor as a guide, someone who is there to listen, to offer encouragement, and to help a young person stay on the path to success. Each of our children has hopes and dreams for their future. Help them get there. Become a mentor.
I'm big. I'm big. I'm big. I've done big things. Some even say I'm bigger than life. But you know what? There's nothing bigger than life. Not when someone you love is fighting to live. You want to do something big? You want to do something big? Sign up to donate marrow and save a life. Take the first step at bethematch.org. See how big you can be. You could be the one to save a life.
What does hope look like? It's in the rising walls of a home rebuilt, raising the spirit of a community reborn. What does heart sound like? It's in the rhythm of nails pounded into wood, a beat driven by the conviction that inspiration can overcome desperation. What does home feel like? It's in the faces of Americans who built generations of memories in their home and then saw it slipping away, until friends they had never met turned out to lend a hand. For more than 30 years, Rebuilding Together has spread hope to homeowners in need, providing free home rehabilitation, making homes safer and more energy efficient. This is a place where you can turn dreams into reality. Go to rebuildingtogether.org and share the feeling of home.
Welcome back to About Health. And as you probably noticed, I'm holding a book. The book is called Focus on Your Health. It's very seldom that you read a book that you wish you'd written yourself. But this book was written by Dr. Brenda Spriggs and Dr. Glenda Newell Harris. Dr. Spriggs has been kind enough to join us. Thank you very much.
Thank you.
Dr. Spriggs, obviously you've had a reputation across the country as one of our most distinguished specialists in rheumatology. What made you decide to write a book? And the reason I ask you is because the African American Wellness Project was really founded for this reason, was to enhance and empower African Americans to take better care of themselves through utilizing the healthcare system more effectively was one of our objectives. What made you write this book?
I think the practice that I had motivated me in some ways. I practiced rheumatology with a subspecialty in systemic lupus, so I was involved with women and girls for over 20 years, teaching at the university, and I found that I did a lot of advocacy because of the nature of the disease itself. And Dr. Newell and I also did advocacy with our friends and our family members, so we decided to put this on paper.
How do you define advocacy? What do you mean by that?
Advocacy is taking a person through the process of coaching them as to how they can get better clinical outcomes, how they can communicate better, navigate the system, and advocate for themselves and their family members.
You know, I used to have an expression in the communications career that I've had, that if you got as mad as African Americans about your health as you do when someone cuts in front of you in the Safeway, we wouldn't have health disparities. Now, obviously, you've done this in a much more organized fashion. What are some of the most important things that we need to do, anybody needs to do, but specifically from your experience as African Americans, to get a better health outcome?
I think I could break that down into three really important points, and maybe a fourth. One is access. Know what your access points are. Know how you get into the doctor's office, into the hospital, or to any other healthcare provider that you might need. The other is to have an arrangement. What's that arrangement? To know that you have a primary care physician to take care and anchor your healthcare needs. The other is to be adherent, and that's a big problem that we're having now.
That's a new word for compliance.
That's a new word for compliance,
right.
Adhering to the medical regime for better clinical outcomes. And I think another term that I would use would be audacity, to know that you can be bold in this environment that we're in and have expectations for improved health care.
Yeah, and I think that that's so critical. Take us through, kind of a brief trip through the book. Obviously, we can't do that in the time that's allowed, but what can people expect when they read this book?
Well, it's very simplistic, it's readable, and it's relatable. We deal with three features which we've identified as the miscommunication and the gaps in health literacy, and that is communication, navigation, and advocacy. It's broken down into those three chapters. We have vignettes, which are true clinical stories, which we've been involved in. The names have been changed, of course, in some of the circumstances. However, they really point to some of the issues that we deal with the healthcare system, whether it's access, medications, or following through with appointments and management plans.
Yeah, when we talk about access, the access point for most of us, whether we're adults or you have children, is that primary care doctor. Too often we see two things happen in that scenario. One is that a primary care doctor is assigned to people. And secondly, that once they get one they don't like, they don't know how to get away from it. What are the proactive steps that you think people should take when they decide to get a primary care doctor? Well,
I think first of all, referrals to doctors typically come from people who've been to the physician. They know them, they can refer them. Self-referrals are really big, and they always have been. So I think that is a key thing, to know who your doctor is, who's been to him, and what their circumstances have been and what their outcomes have been. Now, you said there are three arms to the book. What is the second arm? Or did we talk about all three? We talked about all three, the communication, navigation, and advocacy. I've often wondered from your book, what is the role of the individual in this whole process? For instance, we talk about adherence. It's a new term for non-compliance. And in the medical home concept, it looks almost like we're moving further away from personal responsibility, because in a medical home, I have all the responsibilities and the patient has none. But I don't mind saying it. How often do you think poor outcomes are related to individual choices that people make about how to use the healthcare system? A great deal. You know, there are 90 million Americans who do not have the level of health literacy that they need. When we talk about health literacy, we're talking about the ability to obtain medical information, to process it, and to utilize that for better clinical outcomes. They don't have it. And it's costly, $236 million a year due to poor health literacy. So that's poor choices of medical care, going to the emergency room, taking the wrong medications, and it lends itself to, first of all, healthcare disparities, because you're not doing what you're supposed to do, so you have a gap in what you should be getting from your health care, and it leads to costly medical expenses. And
finally, you know, in so many instances now, we're seeing families have to care for either older people in the family or relatives who are sick. Are there in your book? Do you discuss the role of the caregivers and what they should be doing in order to be effective advocates for people they're taking care of?
We do talk about that in the advocacy section, but what you're referring to is what we mentioned in the book about the sandwich generation. Those individuals who are taking care of the parents, the kids are getting out of the empty nest syndrome, and they're trying to take care of themselves. So caregivers, the careworn woman, is something that really needs to be addressed.
Well, Dr. Brenda Spriggs, thank you for taking the time to join us.
Thank you for having me.
We'll be right back after this break.
When I grow up, I want to be a psychologist or a therapist.
I want to be a pediatrician.
I was hoping to become a chef someday.
I want to study law. I don't want to become a lawyer. I want to become a CIA agent.
Young people, I think, do need a mentor because, you know, we don't know everything. And, you know, all the people, they've experienced stuff that we haven't.
I would like to be a baseball player.
As long as there's somebody behind you, pushing you and supporting you, then you feel that you always have the strength to keep going.
Each of our children has hopes and dreams for their future. Help them get there. Become a mentor.
What does hope look like? It's in the rising walls of a home rebuilt, raising the spirit of a community reborn. What does heart sound like? It's in the rhythm of nails pounded into wood, a beat driven by the conviction that inspiration can overcome desperation. What does home feel like? It's in the faces of Americans who built generations of memories in their home and then saw it slipping away, until friends they had never met turned out to lend a hand. For more than 30 years, Rebuilding Together has spread hope to homeowners in need, providing free home rehabilitation, making homes safer and more energy efficient. This is a place where you can turn dreams into reality. Go to rebuildingtogether.org and share the feeling of home.
I'm big, I'm big, I'm big. I've done big things. Some even say I'm bigger than life. But you know what? There's nothing bigger than life. Not when someone you love is fighting to live. You want to do something big? You want to do something big? Sign up to donate marrow and save a life. Take the first step at bethematch.org. See how big you can be. You could be the one to save a life.
It is so easy to give back.
I don't have a lot of money to help people, but I do have something. I have time.
Get up and do something.
Just imagine how strong a society we could be.
Every one of us has a role to play in making our communities and our country stronger. Discover yours. Help us continue to make a difference in the life of our nation. Go to serve.gov and find the opportunity that works for you. And this message is brought to you by the Corporation for National and Community Service.
Hi, I'm Ellen Bryan, a Miss America hopeful from Ohio. This is my sister Christina. 9 years ago, she was struck by lightning while working on a golf course. Her injuries were extensive and permanent. Christina and I are here today to tell you how to protect yourself. Lightning can strike up to 10 miles away in all directions from a thunderstorm. If you see lightning or even just hear thunder, go indoors and stay there until 30 minutes after the storm has passed. Just remember, when thunder roars, go indoors.
Welcome back to About Health. I'm your host, Dr. Mike Lenoir. You know, we've made significant progress in our treatment of patients with HIV and AIDS. Much has changed about the disease. Yet some populations, particularly minority populations, African American and African American women, suffer disproportionately. I thought it'd be a good time to catch up on where we are in our struggle against HIV and AIDS. Our special guest is Dr. Anthony Jones. Dr. Jones is an HIV specialist and is legendary for his work in this disease. I thought he'd be a good guest to talk with. Thank you for joining us.
Thank you, Dr. Lenoir.
Dr. Jones, tell us a little bit about how HIV has changed from the time you started until where we are right now, and what's different.
Certainly, in my early experience with HIV, it was a devastating time. People were dying of very unusual conditions at very young ages, pneumonias, cancers, and various other conditions. And so In the early days, HIV and AIDS was a death sentence. And over these 20 to 30 years, the condition has changed dramatically. Our knowledge about the virus has changed, and the way that we use medications and combinations compared to how we treat it in the early years. It's gone from being a pretty certain death sentence on diagnosis to a condition like a lot of other chronic medical conditions that can be treated with medication and give people a normal life expectancy.
Yeah, people think that we can cure AIDS, and since whenever you have a sense that you have a curable disease, a lot of the adherence issues drop by the wayside. What are you seeing in communities at high risk from AIDS in terms of changes in behavior, which are so important in controlling the disease?
Well, as you said in your intro, the African American community and other communities of color are disproportionately being affected. And so a lot of the knowledge that we have about HIV and how it's transmitted and risk factors and behaviors, those messages haven't gotten to some communities in the ways that they can be most effective. And so what I see is that a lot of, especially young people in some cases, a lot of people who don't realize that they are at risk, who view themselves as not being at risk, are somewhat sitting ducks for being exposed to and contracting HIV. So I think that maybe society's become a little bit complacent, and because people are not dying off in such large numbers and having such devastation globally, or at least in this country, as to the same degree as before, I think a lot of the messages are just not getting through, and people don't have the same sense of alertness and proactive positioning in order to try to protect themselves from becoming HIV positive.
What are you seeing in the whole testing arena? I mean, are people more routinely getting HIV testing, or did it peak, or what's happening with that? Because testing is so critical. I mean, because so often this disease doesn't present with symptoms until later in the game. Is that correct?
Yeah, certainly, as you say, testing is absolutely key. It's important to intercare for a patient when they're early in their condition and the disease course, in order to try to preserve their immune function. And so, the story of testing in this country has evolved largely along political lines. Early on, people had to sign special permission forms and go through extra steps in order to get tested. And in some states, including California, we have what's called opt-out testing, where it's folded into other routine types of laboratory tests for general health. And I think around the country we have a patchwork of everything in between. But for certain, people should test in general, and people should test more frequently if they have additional risk factors that may make them more likely to contract HIV.
Tell us about the problem of HIV in African American women.
Yeah, so African American women are vastly disproportionately at risk for contracting HIV. In some cases, 20 times more likely than Caucasian women. And it speaks to probably a number of different factors. For one, just in the African American community, men and women tend to learn their diagnosis late, and so they may have more opportunities to become infected and become positive. And certainly women, African American women, tend to not interface with the healthcare system as much. I think that they may have different theories or competing priorities: child care, adult care, parent care, work, etc. These types of things have somewhat traditionally maybe stressed African American women to put their health second. And then again, a lot of African American women and other men in some cases, they don't see themselves as being at risk. They say, I've only had one partner, and so, but unless that partner's been tested, there's no real way to know or to gauge a person's risk without really being tested.
Well, once you enter the system, obviously our approach to treatment has changed. What has been the biggest change in treatment? And as I understand, the HIV virus mutates pretty quickly. What are you doing that makes things so much more successful?
Well, in modern times, we use combinations of medications, and so we know that 3 is kind of a magic number. So if we hit the virus from 3 different angles and maintain adequate blood levels of the medication on an ongoing basis, the virus can pretty effectively remain under control. And so over time, medications have become, the treatments have become more simplified. We've decreased the number of pills necessary to complete a regimen, and there's co-formulations or combining multiple medications into single pills or double pills. And so over time, treatments have become more simplified. I think that's probably one of the biggest inroads that we've made that has helped our patients to become more compliant with their treatments.
What are you most excited about now that you are in this phase of your career about this disease?
Yeah, there's the people, a lot of scientists, bench scientists and others say that HIV is pretty unique in the rapid expansion of the knowledge and understanding of the condition, as well as the development of the medications and the targets where we hit the virus itself. I really do believe that there's going to be a cure, and there's a lot of active research working towards a cure. But we've come from a point where I was in the hospital seeing 20-year-old men die of lung cancer and other conditions to now men and women can start families. Women can have successful pregnancies and deliveries and deliver negative babies. With sperm washing technology now, men can father children and start families. And so people really can, even at this point, live a normal life expectancy. And with PrEP or pre-exposure prophylaxis, couples that are discordant or where one partner is positive and one's negative, they can have fulfilling, intimate relationships and really minimize the risk of transmission to their negative partner. So we're in a really great place now, and I do think that things will be better in years to come.
Dr. Anthony Jones, thanks for all you do, and thanks for joining us.
Thank you, Dr. Lenoir. It's great to be here.
Thank you for joining us on this edition of About Health. A lot of interesting topics. Hope you got some information that you can use. Remember that health is your biggest asset. I'm Dr. Mike Lenoir. We'll talk again.